My brief is to talk to you about posterior fusions for AIS in 7 minutes. It's the workhorse of AIS surgery. I think all of you sitting here, at least the Indians, are very happy to do this from the back, pretty different from what Salil showed us, which is quite an elegant technique. The goals of surgery for posterior fusion remain the same, and the steps, of course, remain the same. So I'm going to take you through, some key elements in the steps of posterior surgery. I think what is humbling or what is almost disappointing is that almost 25% of correction happens just by giving a prone position in general anesthesia. And it's sometimes, you're left red-faced when you have a handsome-looking X-ray and you're doing a demo surgery. And when the videographer shows the intra-op picture, the delegates are pretty sad because the curve looks almost set. It looks straight because you've released the muscles and the patient under general anesthesia. But it's good to know that because it's a surgeon-friendly issue. The next thing that most of us today do is facetal releases. So facetal releases or Ponti's osteotomy is a type, an extension of facetal releases. So you start by doing an interspinous release. After that, you start taking down the inferior articular process of the superior facet, and then go knock down the superior articular process of the inferior vertebra, and then lay open this entire V. And then if you wish, you can release ribs also. The question is that should you do this before passing screws or after? Most of us are comfortable passing screws and then doing the releases, but it can be hazardous because Ponti's osteotomy originally was described for kyphosis when the interscrew dimensions were much more, as you can see in this picture. But when you do it for scoliosis, once you put the screws, there's almost no room left to do a good Ponti's osteotomy, and you can be left struggling. And if it starts bleeding there, then you're in trouble. So the take home here is that you want to do your releases before you pass your screws. How much is adequate? Again, as an orthopedic surgeon, you might think that the more the merrier, but there is something called the law of diminishing returns, and the more you do, the less you get. Also, the bigger gap you leave behind, there's a potential for a loss of coronal correction over time, and hence don't just go home thinking the more you remove, the better it is. Even pseudoarthrosis, though mostly we don't see it in AIS, there's potential for pseudoarthrosis if a big gap is left behind. Not to talk of epidural bleeding. For those who do this regularly, you know that it's a real scene spoiler if you've done a big Pontes and it just can't stop bleeding from there. So you may get away by actually taking down only the inferior articular process of the superior vertebra and leave behind the superior articular process of the inferior vertebra, because there's some data coming in that suggests that as per this law of diminishing returns, even if you leave behind the SAP of the lower vertebra, you can still get reasonably good correction at that level without going into the complications of bleeding and even nerve root injury. Now here's one of my patients. We were operating this guy, and right at the apex there on the concave side, we started doing Pontes releases, and unfortunately we were doing this after the screws were passed, which was quite silly in retrospect, and we had a major potential drop, and this child woke up with one leg weak on that side. Fortunately, he picked up. The point here is that when you're doing a concave osteotomy in a pretty, short apical kind of a curve, you want to be very careful because the cord is draped on that side. It's not an open house for you, and there's a high chance that if the last bit of your osteotomy, especially if you're not using a burr all the way down, you can actually hit the neural elements. These kids are typically hypokyphotic, and hence the cord is at the posterior corner, and it's right under your, the place where you're working. So you got to be careful, and I think burrs are safer to be used here than the regular rongeurs. The next issue is about getting anchors in when you do a posterior surgery. Freehand is the best. I think it's been shown across papers. So you want to use the freehand technique, and the tip to follow here is that you use the spinous process as your guiding light and go in convergence with the spinous process. This is kind of eyeballing, but if you skeletonize the spine, the more you skeletonize the spine, the better you dissect, the more your 3D landmarks come into play. There's a good trick that most of us use, is that if it's a really badly rotated apex, we like to use the convex screws first because they're safer. Even if you have a medial interference in the canal, the cord is far away, it's on the concave side. So put the convex screws and then use them to derotate. And once you derotate, the pedicle on the concave side looks at you much better. And then you can pass the concave screw. A pedicle that looks terrible on an X-ray will look much better once you've derotated intraoperatively, and you could get a better angle. In some hazardous cases, like redo scoliosis and, where some fusion has been done before and your landmarks are not so good, we've been using 3D CT guided 3D CT models, and like this case, my boss actually had done this early onset scoliosis with a heart cell rectangle, and of course it came back as the child grew and to pseudarthrosis and kyphosis, and it was the landmarks were obviously very bad, and it was like the surface of the moon, and you had to find the pedicles. And here we use these kind of 3D jigs, if you may, which sit like a template on the posterior surface of the moon, if you may. The posterior elements just look like one big blob of bone. For those who have visited this, you put this like a face mask on top of that, and that guides you through into the pedicles, and you can get a great correction, a great pedicle screw using these jigs, and it's very inexpensive. For the Indian audience, it costs you about 3,000 rupees per level, and you typically need it for the 5 or 6 apical levels only, so it's much cheaper than using navigation, may not navigation, but maybe robotic for sure. Corrective maneuvers, just a few things that we throw away distraction as a bad thing, but ask yourself, if you had to bend a rod which was so curved, what would you do? You would stretch it out, isn't it? So there's a rule of 60, that any curve that has to be brought down to 60, anything over 100, your first bit of correction is by distraction, whether you like it or not, and that's the simple biomechanical rule. So don't discard distraction. The tip for cantilever technique is that stiffer curves, I would suggest use the cantilever technique and the convex rod as your working corrective rod, while in a more supple curve, you can use rod rotation as your technique. However, when you are using a rod rotation technique, remember that intuitively when you rotate the rod, there's a anti-clockwise rotation or a wrong rotation of the vertebral body, and you get a worsening of a rib hump. So you got to have control on the rib hump when you're doing a rod derotation. Everything looks hunky-dory because the rod gets straight, but the rib hump actually worsens. Don't forget to do DVR for all before you actually finalize your fixation. A quick word on posterior fusion. The issue is that the Hibbs fusion, the classic fusion, was described when you had a very low implant density like this. Sorry, I'm just running over time for a minute. I hope that's all right. So when you had a few anchor points, you had a lot of bony surface area to put in bone graft. But today, with such amount of implant density, there's very little space available for bone grafting, and hence you got to get it really right. You got to, like I said, skeletonize everything. And we try to look into literature to see if implant density causes pseudarthrosis, but really there's no such literature available, barring the fact that there is literature suggesting that less implant density is good enough, and you don't need to have 100% implant density. The debate about which kind of graft to use has been laid to rest, and today you can safely use a mix of autograft with some bone filler substitutes, and Dr. Sukato has some good work on this also, and I would say that's the final word, because it's a good prospective outcome analysis, which suggests that you don't need to really harvest from the iliac crest. And if you have a bridging defect that needs to be bridged after osteotomy, Harms has described using a mesh, and so also these authors from China, and we sometimes use rib grafts to cover these defects. That's it from me then. Thank you.